The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/KQZ860. Downloadable slides and practice aids are also available.
Hello, and thank you for joining us today as we discuss precision decisions in genomic testing and targeted treatment of non-small cell lung cancer. I'd like to thank you for joining us and take this opportunity to introduce our faculty. We've got Joshua Baumel. Dr. Baumel is at the University of Pennsylvania Perelman School of Medicine. We've got Paul van der Laan. Dr. van der Laan is at Beth Israel Deaconess Medical Center. And my name is Dara Eisner. I'm a pathologist at the University of Colorado. Dr. Baumel is an oncologist who will be talking about targeted therapy. And Dr. van der Laan is going to be talking about some of the logistics of testing arrangement from a pathologist perspective. I'm a molecular pathologist, and I'll be discussing some logistics today in terms of the technicals of testing. With that, I'd like to give you a brief overview of the plan for today. We're going to start with a virtual seminar to talk about the expanding cadre of targeted therapies and the growing role of molecular testing in non-small cell lung cancer. From there, we will move to talk about some of the logistics involved in testing, including the management of specimens and some of the details of how testing impacts interpretation of results. With that, I'd like to transition and move to Dr. Josh Baumel. As I mentioned, he's from the Perelman School of Medicine at the University of Pennsylvania, as he gives us a session on the expanding treatment landscape and the growing role of molecular testing in non-small cell lung cancer.
Thanks so much, Dr. Eisner. And thanks so much for having me today. Excited to speak to a bunch of pathologists, if virtually. This is a very important topic. And as we'll see, molecular testing has a huge impact on my patients' lives on a day-to-day basis. And I want to show you how that is. And so when we look at adenocarcinoma of the lung, this pie chart on the left side of the slide shows some of the alterations that have been identified that drive specific subgroups in non-small cell lung cancer. And on the right side of the slide, you can see the results of decades of work here in terms of targeted therapies that are now approved in the treatment of lung cancer. So what you can see, if you look at those columns, there are rows. There are 7 separate targets for which there are FDA-approved treatments in non-squamous non-small cell lung cancer, and these can also occur rarely in squamous disease. So what we have is a complete paradigm shift where the best treatment for a patient is not necessarily chemo, is not necessarily immunotherapy, and we have many treatments that can really change the outcome for our patients. And if we look at the response rates, this is what I'm talking about. The response rate to these drugs is so good that it basically is the point that when I see a patient who has one of these driver alterations, I start them on a tyrosine kinase inhibitor. I generally will say to them, look, you have metastatic lung cancer. You feel ill today. You're going to start this medicine, and tomorrow I expect you to feel better. And that is exactly what can happen. So this is really remarkable and very gratifying to treat patients in this way. So given all that I said and how amazing it is, how are we doing on testing? Turns out, not so great. So this is from data from 2017, 2018, and I certainly hope we're doing better than this. But if you take a look at the amount of patients who actually undergo the appropriate testing for EGFR and ALK, which we've had data on for years and years, it's only about half of patients. That's a big problem. That means that we have a huge group of patients that are not getting the testing needed to identify if they have these very important targetable alterations. And even more concerning, patients who actually are known to have those alterations don't always get the targeted therapy. That's a big issue. Because if I know that a patient has an EGFR mutation, I specifically should not be giving that patient immunotherapy, which would be the standard of care in the absence of an alteration, because we know it doesn't work and is associated with toxicity. And yet here we can see that's exactly what's happening. So what are the barriers to not giving patients targeted therapies? I hear about this all the time. Tissue insufficiency. You go and get a biopsy, it's too small for our lovely pathology colleagues to do what they've got to do. There's concern about the cost of the testing. There's concern about, do they have a good enough performance status to get treatment? The long turnaround time. Education is really, in my view, the absolute most important barrier, where the treating providers simply are not aware of what testing needs to be done and how we can act on that testing. And then another important issue coming from the patient side is often patients say, look, you just told me I have lung cancer. I don't want to wait 2 weeks. I want to get started now. So when we think about that, and you guys look to this as pathologists, how can you help in that process? So one point is that this is changing. So I think that when I'm speaking to this audience, I'm sort of preaching to the choir. You guys know how important molecular testing is, but these conversations are going to evolve over time. And it's based on some recent data. So the first one that is really going to change the landscape is that we're going to start asking for testing in earlier stage lung cancer based upon recent data. So taking a look at EGFR mutant lung cancer, the osimertinib data from the FLORID trial clearly showed that osimertinib is remarkably effective in the setting of metastatic disease. And so there was a thought, well, could we use this in earlier stage to try to improve outcomes? And so that's exactly what they did in the ADAURA trial. All the osimertinib trials end in aura. So FLORA is first line aura, ADAURA is adjuvant aura, very clever. Anyway, this trial took patients with localized lung cancer. They got surgery, they got chemotherapy at the discretion of the treating provider, and then were randomized to 3 years of osimertinib or a placebo. And you can see these are the disease-free survival data. Remarkable improvement in disease-free survival, which has led to an approval for osimertinib in this space. Now, it should be noted, these data are not quite mature. We don't know about the overall survival yet, but this is going to change the question such that if I have a patient with early stage lung cancer who has surgery, I now want to know after that surgery, does this patient have an EGFR alteration? So these are questions like, now that we know, and I showed you the data, the testing is suboptimal even in the metastatic setting where the role is clear for targeted therapy. How are we going to move this into the earlier stage? So Dr. Eisner, Dr. von der Laan, do you have any comments about this?
Yeah, if we can jump on here, talking about how to move this to the earlier stage. I'll touch on it a little bit when I get to my part, but I think that what you touched on is very important. Education is the key. Just the realization that we need to be testing these patients for an expanding number of biomarker targets. And so not only in the oncology community, but the pathology community to understand the need for this testing. And so I think that to answer your first question, really education is the key to realize that our job is not done when a diagnosis is rendered, but rather testing is certainly needed, both in the advanced stage setting as well as in the early stage, as we're talking about now.
And do you advocate sort of a reflexive setting? Like, what do you guys do up in Boston?
Yeah, that's a great question. And I'll touch on a little bit about that later on. But, there really are pros and cons to having a reflex paradigm of testing where the pathologist is responsible for initiating the testing versus an oncologist initiated testing ordering. To cut to the chase, actually at our institution, we have opted for an oncologist initiated testing paradigm for a number of reasons. But and we'll talk about that, but certainly some of the downsides to relying on an oncologist-initiated testing paradigm is potentially prolonged turnaround time which, as you alluded to, is extremely frustrating and important to have this information as quickly as possible so you can make those treatment decisions as quickly as you can. But then secondly, relying just on the oncologist to order the testing, potentially we might be missing some patients. Some patients might be slipping through the cracks as far as having testing ordered or ordered on the most appropriate specimen. And so really communication is the key. And we'll touch on that a little bit more later on in the presentation.
Yeah, I think that that's so true. I mean, the one advantage we have in the adjuvant space is that if patients are going to receive chemotherapy, we do have a little bit of time to get that testing done. So the turnaround is not as critical, in my opinion, but I think that the concern for people falling through the cracks is a major issue. So let's move on to start talking about some of the other things that are going to come up. So often I joke that when I get a second opinion, they'll often say, the tumor was tested. And I'll say, well, what testing happened? And they'll say, well, it was tested. And I think that we're going to need to know more granularity about these alterations as we're learning more about different targets. And I think the best example of that is EGFR exon 20 insertions. Now, we spoke about EGFR mutations in the last section, noting that they respond beautifully to osimertinib, but it turns out that up to 10% of EGFR mutations in lung cancer are these exon 20 insertions that actually are relatively refractory to osimertinib and have a worse prognosis. You can see here on an in vitro characterization curve on the right that these are relatively resistant relative to a classical exon 19 or L858R mutation. But we are now seeing some data that some new drugs, specifically mobocertinib, which is a tyrosine kinase inhibitor, can inhibit the exon 20 insertions. And there's also a new drug called amivantamab. Both of these drugs have been granted breakthrough designation for exon 20 insertion. And, this is interesting, actually. Their data that they presented showing a 40% response rate to non-small cell lung cancer harboring an exon 20 insertion, they were actually able to break it down by subtypes of the exon 20 insertion, where it is on the loop, which might make even more of a difference for a tyrosine kinase inhibitor that functions intracellularly than a bispecific monoclonal antibody like amivantamab. But that level of precision is going to be where we need to go. And if we think about the way people are testing right now, this may simply be inadequate. And so this was from data that we presented at World Lung, which looked at from AACR Genie and Foundation Insights, we looked at the most common EGFR exon 20 insertions that were found and whether they would be expected to be identified on commonly used EGFR PCR kits. And we found that about half of them would be missed. And so this is really emphasizing the importance of next generation sequencing for these patients, but beyond just next generation sequencing, really understanding what the results of that are. And so we know that these are no longer undruggable. And so how are we going to communicate and teach our colleagues about which type of EGFR testing to utilize and how that impacts their care? Do either of you guys have thoughts about this?
Yeah, I will also be addressing some of this in my section as well. But certainly, as pathologists become more and more integral to being part of the migration of testing from the specimen to the order to getting the specimen out the door, it's important to also take the next leap and become educated on what methods are being used. And in many ways, knowing the methods that are being used for your patients can help you to identify the best cases where either you can upfront triage it to a method that will detect these things, or if you need to do it in a stepwise fashion, know what the opportunities are for kind of missed calls, so that way you can revisit those testing paradigms.
And it's so critical to be able to have that communication with a molecular pathologist, because these next generation sequencing reports are really, really complicated. I'm not I'm not a smart pathologist. I'm just an oncologist. I don't know all this stuff. So like when I see it, it can be very overwhelming. And all I do is treat lung cancer and head and neck cancer. For people in the community seeing every type of cancer, this can be truly overwhelming. So one of the other things that comes up though is that it's not just do the next generation sequencing testing, because we're now finding some alterations are better detected using an RNA-based platform than a DNA. The best example of this would be MET exon 14 skipping alterations, which occur in an intron and cause a splice site variation that leads to the loss of exon 14. At our lab at Penn, when we use our internal panel, I usually only identify these on our fusion panel that shows a 13 to 15 quote unquote fusion, whereas our DNA panel will often miss this. And it's a big issue as we look towards the future because we now have two drugs, both capmatinib indicated here, and there's also a drug called tepotinib, which is FDA approved in this space, that have shown very nice responses in MET exon 14 skipping non-small cell lung cancer. And also there's capmatinib has efficacy in MET amplification as well as measured by gene copy number variation. So this is an expanding population of patients who need targeted therapy. And it's going to be complicated and certainly going to get beyond just saying, we did the testing. And so how can we utilize RNA-based sequencing? Is this something that you're using at the University of Colorado or at BID?
We use RNA-based testing very regularly in non-small cell lung cancer here at the University of Colorado, and I'll present some data in a little while on the situations in which it really does prove a benefit compared to DNA-based testing.
Yeah, and here in Boston, we tend to use the RNA-based testing modalities if nothing is found using the DNA-based testing. And we can talk a little bit about that later.
Fantastic. Well, thank you so much for your attention. I will now hand it off to Dr. van der Laan.
Great. Thank you so much, Dr. Baumel. So in my next section, we're going to be focusing on what we as pathologists, as surgical pathologists, as cytopathologists have to think about kind of as that intermediary between our oncology colleagues needing this information and our molecular pathology colleagues who do the testing per se. And as we're all very well aware, the times they are changing, and no longer is it sufficient for us on cytology or small biopsy specimens to just establish a diagnosis of malignancy. We do need to do some focused immunohistochemical characterization of the tumor to understand in non-small, are we dealing with a squamous cell? Are we dealing with an adenocarcinoma? Are we dealing with neuroendocrine tumors? But at all the time, maintaining adequate material for this ancillary and molecular testing that's needed. And as was alluded to earlier, the number of biomarker targets that need to be assayed, it just is growing at a breakneck speed. And so not only are there 7 or 8, depending on how you classify PD-L1, biomarkers that need to be assessed because there are paired FDA-approved therapies, but there are a growing number of both emerging and evolving biomarkers that might need to be assessed in the months and years ahead. So it's very encouraging to see the pie filling in. But again, as a pathologist, we need to understand that the oncologist cannot make those informed treatment decisions until they have the results of that testing. So kind of the first question that is posed to pathology writ large is, where do we do this testing? So we have this tumor that needs this complex testing being done. Do we keep it in-house and do in-house testing, or do we send it out to a reference laboratory? And it's a little difficult to get nationwide data on the utilization of next-gen sequencing in non-small cell lung cancer, but the best estimates that I've seen is that approximately 35% of non-small cell lung cancers that have NGS testing are done in-house, mainly in large academic medical centers or large hospital systems, where 65% of non-small cell lung cancer NGS testing is done as a send out to a reference laboratory. And the pros and cons of both really do need to be considered depending on the local facilities and the personnel, the testing volume, how many specimens are being generated on a weekly basis, what's the turnaround time that can be achieved either way. Obviously, cost and billing issues are at the forefront of healthcare today. And then also the type of specimen. And so if we consider, the types of specimens that traditionally have been tested, on the left-hand side of the screen, it's generally that formalin-fixed paraffin-embedded tissue that is the common denominator for most ancillary testing that has been validated in laboratories. And so for the lung, be this transbronchial biopsies or transthoracic core needle biopsies, or even formalin-fixed paraffin-embedded cell blocks from cytology, that tends to have been the main focus of testing. However, we've all in the cytology community recognized that there are so many different specimens that are generated during these minimally invasive procedures, including smears, touch preps of core biopsies that are generated during rapid on-site evaluation, as well as a number of liquid-based preparations that can be used for this testing. And historically, if we look at a historical view of some of the guideline recommendations, early on in the first generation of the CAP IASLC AMP guidelines, really there was a bias or a suggestion that we should be really focusing on cell blocks as the preferred cytology substrate if we were going to use cytology specimens for testing. In the second iteration, published in 2018, this was broadened, and the realization that we can use many different cytology specimen types, as long as they're validated in their laboratory, really can be prime substrates for lung cancer testing. And this is also recapitulated in the NCCN guidelines, including the most recent iteration in 2021, where that acknowledging, once again, that increasingly we have moving away from just an FFPE specimen as the testing substrate to other cytology specimens that can be very, very good substrates for testing, depending on what your molecular laboratory, either in-house or reference laboratory, will accept. And so if we think about in cytology first, there are so many different specimen types that are generated. One of the beauties of cytology, we have our smears, we have cell suspensions that can be formed into formalin-fixed paraffin-embedded cell blocks or other cell block type methods. Those smears, those cell blocks can be used for immunohistochemistry. They can be used for FISH, and both of them really can be used for molecular testing as well. Some less traditional substrates, including scraping off of cells from liquid-based preparation slides. And something that's been gaining a little bit of traction recently, given the success of the so-called liquid biopsies in the clinics, is we can apply those same technologies to supernatants of different cytology specimens. And so that be the supernatant from a CSF fluid, FNA fluid needle rinse, where historically that has just been discarded during the specimen processing, but there certainly can be valuable molecular information that can be gleaned from those specimens. And so certainly the cytology world, we've seen an evolution of how we're using the different substrates, the different specimens that are obtained during these tests. If we think about surgical pathology, we're all quite aware, especially for these tiny, small biopsy specimens that are obtained via minimally invasive sampling techniques, that resurfacing into that paraffin block multiple times can lead to devastating loss of tissue and depletion of tissue before everything that needs to be done can be accomplished. And so really it is helpful to have rational tissue management strategies developed in your laboratory that on the left-hand side of the screen illustrates the utility of cutting a number of unstained slides up front that can be used for diagnostic immunohistochemistry, that can be used for FISH or next-gen sequencing, again, depending on what your testing paradigm is. And then another very logical thing that you can do in the laboratory is with these small biopsies, you can split them into multiple blocks and use those blocks differently. One block might be used for diagnosis, diagnostic immunohistochemistry, et cetera, and preserving a second block just for ancillary studies. Or if you are in a send-out paradigm where you might be sending out your tissues to multiple different laboratories, you can actually send those two blocks out simultaneously to, again, facilitate a rapid turnaround time. So that really kind of gets to the logistics, a thought about the logistics behind what to send to your molecular lab. Again, be that in-house or a send-out reference laboratory. Most of the time, we are sending unstained slides or paraffin blocks. But the question comes up, is it good enough just to send that block? Some commercial laboratories and some in-house labs have more stringent guidelines of what they want to see. An annotated H&E slide is very helpful, especially if it's not a uniform tumor throughout the slide. So some degree of macro dissection of the tumor tissue can be done to help enrich the tumor purity and the tumor content that will be tested. Certainly in specimen types like pleural fluids, where there is an intimate mixture of tumor cells with mesothelial cells, lymphocytes, histiocytes, actually sending along either an image or the immunohistochemical stains to the laboratory can be extremely helpful, again, to help them understand what is the tumor purity, where are the tumor cells, what cells should be interpreted in FISH assays, for example. So talk to your lab, understand what they need, and how can you make their job easier to ultimately help the ultimate success of this testing. If you are using a send-out paradigm, you might be able to do the PD-L1 testing in-house, but next-gen sequencing at the reference laboratory. Something to consider is whether to send the entire block to the reference lab. Will that be more cost-effective, or is it better to use those upfront cut unstained slides through the IHC in-house, even though the oncologist might have to wait until all that NGS data comes back in order to make the most informed and the appropriate treatment decision for that patient. Another thing to think about is if you have a specimen that's paucicellular, it's the best specimen you've got, but it really doesn't have a very high tumor cellularity or tumor proportion, do you have a rescue option? Are there ways that you can either use a different laboratory, send to an academic medical center, or send it to a laboratory where they might be able to do some sophisticated enrichment techniques like laser capture microdissection or single cell capture to boost the signal of those tumor cells? And so that's something to think about. And then finally, we've been dancing about this a little bit, who orders the testing? And that's very important to think about, the two main ways that testing is done these days. We can have the reflex testing paradigm where the pathologist who knows the specimen best can initiate the testing, versus the oncologist initiated testing. The oncologist who knows the patient the best would initiate the testing. Obviously, as alluded to earlier, there are pros and cons of one route versus the other. For a pathologist reflex testing paradigm, it really can increase testing rates to ensure that things don't slip through the cracks. Downside, of course, being the risk of over-testing and issues of increased costs and potential reimbursement issues for doing too much testing. It certainly decreases the turnaround time that the oncologist effectively sees from that specimen. We can start that clock early. We can get the testing into the pipeline so the analytic phase can be addressed by the molecular lab as quickly as possible. And again, the quicker we get the information to the oncologist, the quicker that patient can be treated. And then lastly, the pathologist is the best one to know what is the best specimen. Oftentimes in these bronchoscopic procedures, we have transbronchial biopsies, we have transbronchial needle aspirations in cytology, we have EBUS TBNAs of lymph nodes. We know which one of those specimens is the absolute best specimen. Obviously, we know if there's been decalcification. Acid decalcification is clearly bad, whereas EDTA decalcification is a viable option for many molecular labs. And then also an assessment of really tumor proportion and purity, what's the best thing. So The pathologist knows the sample best. On the other hand, the oncologist knows if testing is needed. Has it been done previously? Is this primary diagnosis or a disease recurrence where a different testing paradigm might be incorporated? What is the stage of this tumor? Is it early stage that will be going to surgery, or is it advanced stage where we'll definitely need this information on this preliminary biopsy specimen? Pathologists might not always know that information based on LIS or electronic medical record access. The oncologist is the best one to know what testing is needed. Do we need more comprehensive genomic profiling on this particular specimen versus do we need more of a focused answer? Is there a specific question the oncologist has based on a disease progression on therapy? Is there a liquid biopsy, a blood biopsy that's pending or testing that might either be complementary or maybe replace tissue testing in that situation? Again, the oncologist is the best one who knows there. And then finally, the oncologist knows when that testing result is needed. They know if there's a very clinically urgent case. Obviously, we want to always get the information to the oncologist as quickly as possible. But the performance status, how quickly the therapy needs to be initiated, is something the oncologist knows more about. And then also, again, with the urgency, is this advanced stage or early stage? And the latter hand, we'll talk about it a little bit in the next few slides. We might have a little bit more wiggle room with the turnaround time on testing in earlier stage specimens. And so oftentimes when we think about molecular testing or ancillary testing, we get so hyper-focused and we focus on the actual testing or the actual analytic phase that's done in the molecular laboratory. And that certainly is a potential time period that there's minimal things that can be sped up. So there's a finite amount of time that this testing requires. However, from a patient safety standpoint, as well as a logistical standpoint, I think we in pathology really need to think about the pre-analytic testing phase. And this is very, very broad and covers things such as the specimen processing. What's the fixation time? What's the fixation method? Has it been decalcified? The collection method of the specimen, either on-site for cytology or during these minimally invasive procedures. And then also things that might seem a little bit more mundane, the ordering, the accessioning, the transport, all things that can really lead to either errors or prolongation of the effective turnaround time that our oncology colleagues see. And this really is a system. This is a system-based practice where there is shared ownership for these processes. And of course, you will have primary ownership along the chain of command, depending on what phase you're looking at. But certainly there are other areas where this decision-making, that this responsibility is shared between pathology, between the clinicians, and with the reference or in-house molecular laboratory. And so again, something to really think about, what is our role in pathology and how do we maximize testing success and testing turnaround time. Now, as alluded to earlier, the AD-AURA results really is potentially a sea change and something that can really be a paradigm shift for how we think about testing in pathology. So this really is opening the door to that we're no longer hyper-focused on solely advanced stage non-small cell lung cancer for testing, where the only specimen we're going to have is that diagnostic biopsy specimen, and those testing results are going to be needed for most appropriate therapeutic choice. Now on resection specimens, where we have more tissue, we don't have to necessarily worry about quantity insufficient. That is something that does plague these smaller biopsy specimens. We now know that because of the potentially dramatically increased disease-free survival of patients with EGR sensitizing mutations treated with osimertinib, the oncologist will need to know whether or not that resected early-stage lung cancer has an EGFR mutation or not. So right now, EGFR is really that prime candidate, but you can very clearly see that coming down the pipeline, we might see similar disease-free and hopefully overall survival benefits for adjuvant therapy of patients with ALK rearrangements, ROS1 rearrangements, BRAF, et cetera, et cetera. So we might be expanding what we need to test on these resection specimens and not just on the small biopsy specimens in advanced stage disease. And again, this brings into the question reflex testing. The pathologist knows at the time of sign up, the time of evaluation of those resection specimens, what's the best tumor block, can we get that testing started very rapidly? But on the flip side, there's argument of this, the pathologist might not know exactly what stage it is. If this is a stage 1A, 1B, there might be little benefit and increased cost to reflexively ordering these testing on all of these resected specimens. And also as what Dr. Baumel alluded to, we have a little bit more time in the adjuvant setting. The patients had hopefully a curative intent surgery performed. And so the need to start therapy in the adjuvant setting isn't as pressing as it is in the advanced stage setting. So to conclude this part of the session, I want to let 3 points sink in for all the pathologists in the audience. Number one, in the setting of non-small cell lung cancer, we need to test. And to play a twist of words from my native home, Chicago, we need to test early and test often. Test these specimens so we can identify those targetable mutations that can lead to better drug selection, better overall survival, and better quality of life for patients with lung cancer when the paired therapy can be matched with that tumor. Secondly, we very much recognize that these are complex systems and we need to have a plan. We need to have a plan for how to optimize the diagnostic approach to these specimens, minimizing the upfront immunohistochemical workup, minimizing the tissue used on these small biopsy specimens, minimize any potentially adverse ways these specimens are handled. Decalcification, fixation methods, etc. So we need to have a good plan about how to handle these specimens and then also have an eye towards logistics. How can we streamline this process? Where can we identify the pressure points and the potential bottlenecks in these processes that are increasingly recognized to be manual labor and very labor-intensive events in pathology, despite a lot of the automation that we've been working towards over the last decades. And lastly, coming back to this common theme, communication is absolutely key. We need to involve all stakeholders. And as pathologists that lie, again, between our clinical colleagues on one side and our molecular pathology colleagues on the other, we are those intermediaries. And so we should do everything we can to help facilitate a smooth transfer of materials and information from one to the other to, again, maximize that testing success. And so to hear a little bit more about, again, the methods of testing and some of the new advances, the next part we'll hand it over to Dr. Eisner to talk about those things in non-small cell lung cancer.
Thank you, Dr. van der Laan. I'm excited to talk to you today as well about some of these practical aspects, but from a technical perspective about the testing. And as much as pathologists can be an advocate for patients in trying to be sure that patients get tested, there are other ways that you can advocate for your patients by knowing enough of the detail of the testing to identify when another round of testing just might be the right thing. So to get to that point, I'm just going to dive right into testing methods and some of the details. Now, as many of you are well aware, in molecular testing, and when we think about mutation testing, we tend to think about the methodology as a balancing act. And on one end of this balancing act is clinical sensitivity, which is really a question of the scope of the assay. How many possible changes does the test detect? And in the opposite direction from that is the analytic sensitivity, which can be best drawn as an analogy to limit of detection. How sensitively can the test detect a rare change in the background of normal? And each of these profiles in terms of a test parameter can lead to false negatives. So a test that has constrained clinical sensitivity can have false negatives because a change is present in a specimen that the test is simply not designed to detect. Conversely, in an issue with analytic sensitivity, you can have a false negative because the alteration exists at too low a level in the specimen, usually because the specimen has an abundant amount of non-tumor in it. Now, I usually like to provide everybody a way to explain this. So I'll call this being in clinicianese. If you think of a haystack, and we often think about finding needles in haystacks, a test with excellent clinical sensitivity is able to detect lots of different colors of needles. A test with excellent analytic sensitivity can get down to one needle per haystack. And the Achilles heels of each of these sort of modalities here is that a test with excellent clinical sensitivity typically will tip towards being able to detect needles of many different colors at the expense of how many needles you need to have in that stack. So you'll need to have a higher level of those needles for the test to work in the best possible way. From an analytic sensitivity perspective, you can easily get down to one needle per haystack, but the Achilles heel here is that you can really only look for one color. And this analogy has worked really well when being able to integrate that with understanding the testing method that was used for a particular patient and whether you really want to think about doing follow-up testing based on the totality of the picture. So when we think about the classic methods that are used today, fairly routinely, I would add, I'll just walk you through three of the most common methods. One is Sanger sequencing, and this is the oldest and tried and true method of sequencing we've had for a long time. Here's an example of a mutation, which you can see. And Sanger sequencing has excellent clinical sensitivity. You can essentially design it to cover as much as you want, but it has poor analytic sensitivity. So it won't do very well in tests with a very high non-tumor burden where that tumor can't be effectively enriched. Next in the list is targeted PCR assays, often called qPCR. And these are highly targeted assays. They only ask very specific questions. So it's really kind of the opposite spectrum here. You can get a very, very precise result looking for a very rare event, but you're only going to be asking a very limited number of questions when you apply a test like this. And lastly, you've got next generation sequencing, and this has kind of broken the mold in the sense that you can ask a wide scope of questions and you can achieve a better analytic sensitivity than, say, with Sanger, but it does have a middle ground, and some of that depends on the exact nature of the NGS. Now, when we think about that analytic sensitivity, which I've said is most analogous to a concept of limit of detection, when you look at a pathologic sample, what we tend to look at from a molecular perspective is not just how much tumor is in the sample, but also how much non-tumor is in the sample. Every single non-tumor nucleus dilutes that signal of a mutation. So you need to consider not only the total amount that's in a specimen, do I have enough cellular material in the specimen for enough extraction to make a molecular assay work, but you also need to think about the tumor cellularity. And that's the tumor nuclei over all non-tumor nuclei and tumor nuclei combined. And you need to modulate this in terms of understanding whether the laboratory you uses enrichment methods. And I will tell you that from my perspective as both an anatomic and a molecular pathologist, we spend a long time learning how to identify those tumor cells in the background of those pesky lymphocytes, macrophages, mesothelial cells, and everything else. And learning to reintegrate those things into your thinking of what's in the sample is actually fairly challenging. I'll also mention that fusions are something that we think about slightly differently from some of those PCR-based methods I just described to you. And I'll tell you that they're a different kettle of fish where I definitely intend that pun. We've typically always thought of fusions or rearrangements as something that we evaluate using FISH technology, fluorescence in situ hybridization. And NGS technology has changed how we think about this to some degree, and we do think about some panel-based approaches to fusion detection. But how you test for fusions really does matter. And this comes down to this question of PCR-based testing versus NGS versus FISH. And to illustrate that, I'm going to go through some examples here. And that's really what I want to focus on today is how do you identify where the Achilles heel of a test is that might lead a patient to have false negative results. So when we think about fusions, I'm going to just call out an example here for Rett fusions. And in Rett fusions, one of the most common fusion partners is the one seen here, where the two genes are together very closely aligned on the chromosome. And this is fairly common for a number of fusion events seen in non-small cell lung cancer, where it's actually a gene inversion event, a genomic inversion event. And that inversion creates two genes next to each other. Now, if you think about this from the perspective of fluorescence in situ hybridization, where at that particular location, say Rett, you are trying to separate these two signals. So if that fusion happens and these signals split, then you can wind up getting a positive on FISH. So here we've graphically represented that it inverted, but because the fusion partner is so close, you can wind up with an underdetection by FISH. Now I'm going to contrast this with fusion detection when you do next generation sequencing that's DNA based. When we do next generation sequencing that's DNA based, essentially we are using the fact that the genome is rather large and has all of this intervening space between the coding regions that harken back to some college level and medical school classes. You'll remember that this is the distinction between exons and introns. And exons are the very small pieces of a large gene that actually lead to coding regions for protein. And all of this stuff in between is introns. And as is represented here, it's very common for the introns to actually represent a much larger part of genomic space than the exons. And in DNA-based next-generation sequencing, looking for fusions, we actually sequence through all of this intronic space, or at least we try to, in order to pick up those rearrangements, because those rearrangements tend to happen in intronic spaces. The problem is that introns can be really hard to effectively sequence. This can be because they are either very, very large and they use up a large portion of the DNA-based assay, or because they have difficult repetitive sequence. So here is from a paper which showed that DNA-based testing underdetects some fusions. And this example is ROS1, where you can see here that we've got a series of intronic spaces. And these gray bars up here indicate the region of the genome that have been covered by NGS. So here I've got an exon, and here I've got an exon. And this entire space in between that's intronic, ideally you want this gray bar covering all of this area to effectively cover this and be able to detect a fusion. But what you see here is that this is dramatically undercovered, and that is because these are highly repetitive regions that are very difficult to sequence. And this is the mechanical or the biochemical reason that we wind up with underdetection of fusions when we do DNA-based next-generation sequencing. In contrast, RNA-based next-generation sequencing, or in some cases, some selected other RNA-based testing, skips over all of these introns and goes directly to that RNA event where, for example, this exon has been fused to a new gene product, creating a gene fusion or a chimeric event. By evaluating these RNA regions, we can basically work backward from the part where we expect the fusion to happen to know what is going on here. And we only need to sequence the exon of interest. Now, the downside here is that this relies very heavily on RNA quality. And as everyone is familiar, formalin fixation and lots of other things can impact RNA quality. And this really gets back to what Dr. van der Laan was talking about in terms of really having a plan for pre-analytic management. To sort of drive this home, the specific circumstances where RNA testing tends to outperform DNA-based testing for fusions include where the introns are very large, because sometimes it can be very hard to create enough coverage of these very large regions, where those introns are highly repetitive, where there's a low tumor sample. And low tumor sample can be rescued by RNA sequencing, because in most cases of an RNA fusion event, that is a highly expressed event that can overcome kind of that dilution effect you get from having a low tumor proportion. And lastly, we are increasingly recognizing that complex genomic events do occur and can lead to difficulties in resolving these questions at an informatics level when looking at it from DNA. Now, you might say, well, how would I know which fusions would be challenging and therefore would be more likely to be false negative with DNA-based next generation sequencing? I will tell you that ALK and Rett on a theoretical basis would be predicted to have less trouble with DNA-based next generation sequencing. And this is just based on the properties of the introns of these genes. However, all of these events have been shown to have false negatives with DNA-based next generation sequencing: ROS1, MET exon 14, and TREC1 and TREC3 and NRG1, which many DNA-based panels don't even cover at all. The proof is really in the pudding when you talk about these things. And what I think is really a landmark paper published in 2019 by the group at Memorial Sloan Kettering asked this question very directly. And what they did is they took a whole cohort of tumors that had been negative for drivers based on DNA-based next generation sequencing and did RNA-based testing on as many of them as had sufficient RNA. And out of 254 cases that they sequenced, they got 36 positive cases that had an RNA-based fusion. That's almost 16% of the cases, and all had been previously negative by DNA-based next generation sequencing. Importantly, to jump back for a moment, this did actually include fusions that might have been predicted to be less challenging. So it did also include at least one case of a Rett. So when you think about fusion detection by next generation sequencing, there are really three types of next generation sequencing that can be used for fusion detection. One is DNA-based next generation sequencing, and this has the problem of having significant false negative for those challenging fusions. There's RNA next generation sequencing by amplicon, and in many ways you can think of this as being like a multiplex reverse transcriptase PCR, where you necessarily know the fusion and its fusion partner. So it's only going to detect fusions where the fusion partner has been well described and is included in the assay. And capture-based RNA next generation sequencing has the best performance for challenging fusions. But again, its performance relies on that RNA quality. Now, moving to the next area, though, to think about this from an integrated perspective and really taking a consultant's role as a pathologist to help oncologists navigate the many different testing modalities, I'm going to migrate to cell-free DNA testing, which is sort of been nicknamed liquid biopsy. The premise of this is that tumors shed their DNA into the bloodstream, most prominently related to tumor cell death, and that those little units of DNA that are shed are protected by histones and can therefore be extracted and analyzed. There's a lovely review in Nature Review Clinical Oncology that's very recent. I highly recommend. It talks about the pros and cons and the differences between tumor tissue genotyping and plasma cell-free or circulating tumor DNA genotyping. And I'll highlight for you that one of the most important things here is this sensitivity piece. So the sensitivity of tumor tissue genotyping is excellent. And as you are probably well aware, this requires multiple layers of review, such that first a pathologist has to send it to a molecular lab, and then a molecular lab evaluates its adequacy. So having those multiple layers means it's much more likely to have the review to make sure it's an adequate sample. And if it's a borderline sample, it will come with the appropriate disclaimers. In contrast to this, plasma-based testing has a compromised sensitivity because you don't really know the denominator or the adequacy of what you're looking at. And so it becomes really important to be able to understand what makes for an informative versus an uninformative cell-free DNA evaluation. This, again, is from the same review, and it gives you a nice potential workflow for considering how to deploy cell-free DNA testing as it relates to tissue biopsy. Now, cell-free DNA testing in practice is often something that is really initiated right out of the gate when a patient has a very scant initial diagnostic sample and a rebiopsy is not feasible. And as was mentioned by Dr. Baumel, it's critically important to have EGFR, ALK, ROS1, and all of the other targeted therapy data points before starting therapy. In practitioners, what I have seen is that many practitioners order cell-free DNA testing at the same time as placing an order for a new biopsy in stage 4 patients. And the cell-free DNA testing may come back before the biopsy is even completed. And in that case, if it's informative, the biopsy order can be canceled. So it's really this critical question of how do you determine if it's informative? So to that end, I've highlighted a few quick cases that we'll talk about here. In this first case, we have a 62-year-old never smoking female. The cell-free DNA testing was negative, but the tissue testing showed an ALK rearrangement. This is not a test design issue. This is because the burden of circulating disease in this patient was low. There was a lower cell-free DNA burden because of confined intrathoracic disease. So in this case, seeing a negative cell-free DNA testing should convince anybody that this is really not a negative, it's an uninformative and should be followed up with testing on tissue. Here we have a patient who's a 58-year-old female with a 30-pack year history. There's a KRAS G12C mutation detected in that cell-free DNA testing. And that KRAS mutation is informative because even though there is not currently a targeted therapy option for that mutation, additional testing is very unlikely to be fruitful. That KRAS G12C, by the way, may be something that comes down the pike in the very near future. Now, in this third example, we have a wide spectrum of alterations, most of which are centered on TP53. And this is a 65-year-old male with a heavy smoking history and a history with previous chemotherapy and immunotherapy. Now, if you look at all these alterations, you might go, well, surely something in this big stack is informative. Clearly, they got some tumor, and we can consider that this patient is negative for KRAS or BRAF or EGFR or all of those things. And what I would argue to you is that this is actually an uninformative result here. Nothing here is definitively from the tissue, the burden of tumor in this patient. The spectrum of TP53 mutations seen here could easily be sort of marrow reactiveness to prior chemotherapy. It has been well documented that you can see peripheral passenger type alterations from chemotherapy. And the IDH alteration could easily be what we call clonal hematopoiesis, or CH. And those are things to be aware of when you look at cell-free DNA testing reports. So truly, when you interpret cell-free DNA testing, it's the absence of a known driver, which makes it uninformative, and those passenger mutations don't count. And ultimately, cell-free DNA and tissue testing are complementary. So what I would say is that you are in a position to be an advocate for the patient by being able to integrate all of the different test results and understanding the methodologies that were used. Understanding when methodologies have left gaps to allow for consideration of follow-up testing, such as DNA-based testing that's negative, leading to follow-up testing with RNA-based next-generation sequencing. For example, as Dr. Baumel alluded to before, PCR-based testing for EGFR under detecting EGFR exon 20 events. There are a number of ways that you can really serve as a critical component of that communication thread that Dr. van der Laan referred to as being this conduit between the molecular testing and the oncologist, and ultimately for the benefit of the patient. So with that, we're going to move to some discussion and audience Q&A, and we'll start by taking a look at some of the questions that have come in from our audience. First, can liquid biopsies be performed with other body fluids, CSF, etc.? How does the yield of cell-free DNA isolated from various body fluids compare with that from cytology samples or small biopsies? Dr. van der Laan, Dr. Baumel, do either of you want to tackle that?
Sure, I can jump in there. So certainly in the cytology literature, there have been a number of publications out recently looking at, again, alternative specimens, supernatants from FNA needle rinses, from liquid-based preparations in, the setting of non-small cell lung cancer, but also thyroid and a number of different tumor types. And a lot of them are proof of principle papers showing certainly good, high quality signals can be identified. And Dr. Eisner, I defer to you as far as the technical aspects, but yeah, it's very encouraging to see from CSF, from the supernatant of pleural fluids, from urine, from a lot of different fluids, there is valuable information that can be gleaned from the liquid part that is usually discarded in the processing of these cytologic specimens.
Great. I agree completely. And I think that we're going to be seeing and hearing a lot more about this type of testing in terms of testing on these fluids. And in many ways, testing of these fluids, when we think about liquid biopsy application to these fluids, is not really that different from what we've talked about before in terms of testing supernatant. It's really just a function of what level of sensitivity the assays are designed for to be able to get those very rare fragments of DNA that are floating around in them. So I thank you very much and for that answer. And I think we will be seeing a lot more of this. Another question that has come in, cell-free DNA tests are now pervasive and they have real value, but they tend to happen in a vacuum with data flowing to the oncologist, and the lab might not know what has happened. Are there ways to think about managing that?
So what we do at our center is every time I get a liquid biopsy, and you're right, they end up in a portal and sent as a document to me, I have every single one of those documents scanned into the patient's electronic medical record in its entirety, so that anyone who's taking part in the patient's care, and there I of course include my colleagues in pathology, can review that to see how it would inform their decision making.
Great. I think, certainly in contained systems such as those that the three of us practice in, that's a big advantage to being in kind of a single electronic medical record. But I can imagine that in some settings where, for example, the pathologist may not have access to the same electronic medical record that the oncologist works in, that would be particularly challenging. I think another way to tackle that is that most of the companies that do cell-free DNA testing will grant access to pathologists for patients that are in common. And so pathologists can work with, so if you have oncologists that you work with regularly, you can get access to those portals and get basically granted access to those reports. And that can help you in decision-making as it relates to sending individual samples. Another question that has come in, should we be routinely testing squamous cell carcinomas? And I'll take that one. Certainly there's a spectrum of opinions and to some degree some debate about this, and there has been for quite some time. The NCCN has recently changed its language in terms of testing on squamous cell carcinomas, where it used to indicate selection for testing based on things like a light or never smoking history or other atypical clinical features. That language has since been largely removed, and now the NCCN simply says consider testing in all squamous cell carcinomas. I think this is in large part because if you think about how easy it is to comprehensively exclude an adenocarcinoma component from a squamous cell carcinoma, well, the answer is that's not a particularly easy thing to do. So on one hand, we can never really truly exclude an adenocarcinoma component for any subtotal sampling of a tumor, which is the typical case for most advanced stage non-small cell lung cancer. And separately from that, we are also seeing that if you test cases that are classified as squamous cell carcinoma across the board, that while the mutation rate for any individual targetable alteration like EGFR or BRAF is quite low, that cumulatively, when you put them together, they really actually start to become fairly significant, and it ranges from 3 to 10%. And so when you put these features together, the lack of ability to exclude an adenocarcinoma component and the cumulative incidence of targetable markers, there's increasing push to test squamous cell carcinomas more routinely. Dr. Baumel, Dr. van der Laan, do you guys have perspectives on that?
Yeah, I mean, I think that our biopsies are often very small. And I've seen many patients who have squamous disease who have a molecular driver alteration. Often they're never smokers, but we have to remember that smokers can get EGFR alterations too. And so we want to make sure we're checking for these.
Absolutely. And, as a cytopathologist, we're used to looking at very limited samples. And so the core biopsies, the transbronchial biopsies, the needle aspirations are only sampling such a small part of that whole tumor. And so we definitely want to give each patient the best chance at a effective targetable therapy, as Dr. Baumel indicated. And so really, yeah, there should be no reason to not test these small samples for the reasons stated above.
Fantastic. I think that's all the questions we have time for today. But before we depart, I'll just quickly ask our panelists to each provide a quick reflection on what they think the message is today. Dr. Baumel, let's start with you.
Well, I think that really the critical element from my perspective is to emphasize the fact that you as a pathologist, and speaking to our audience here, can have a real impact on patients' lives by communicating with oncologists and ensuring that the appropriate test is done in a timely fashion. This really makes a huge impact for patients' lives. And it's been a real joy to be able to collaborate with our team at Penn to make sure that patients get this testing done.
Dr. van der Laan.
Yeah, thank you. This has been a fantastic session, and I really think that the multidisciplinary look at this problem has been super helpful, and hopefully helpful for all those watching. I think that the two quick points that I'd like to make is, number one, in non-small cell lung cancer, things are changing so rapidly. The number of testing targets, the number of therapeutic options makes my head spin, as so many people in the lung cancer field must be feeling. And so you can only imagine the community pathologist or the general pathologist, how do they keep up? And so it's great to try, as a pathologist, to try to keep up with these things. And the second point is that I think that the paradigm and the model that non-small cell lung cancer testing has established really will over time bleed to other tumor types as well: pancreatic cancer, colon cancer, melanoma. So the lessons learned by pathologists here in this setting can certainly be applied to other tumor types as well. And so we just got to keep on learning and do everything we can to, again, facilitate rapid results and the most effective results for our oncology colleagues.
Great, thank you. And I'll just tie that up by saying that I think that there's a lot of hope in this arena, and that we're able to bring a lot of hope to patients through the ability to converge between oncology, pathology, and molecular testing. And my perspective on this is that knowing some of those details of the testing can help you really aid patients in those rare events where you identify something that might have slipped through the cracks, not intentionally, but because methods, there's no such thing as a perfect test. And so with that, thank you very much for joining us today, and enjoy the rest of your USCAP meeting.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/KQZ860. This activity is supported by independent educational grants from AstraZeneca, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, Novartis Pharmaceuticals Corporation, and Takeda Oncology.